mission.
Hi.
Ron, I think it was a very good idea that we do the VITS-RHI presentations together. So I am the second of the three musketeers, and I'm going to be speaking, as Rue mentioned, on the social work component of the program. I also want to, at this point, I think before I even begin, just pay tribute to Ron, because Ron has played a very fundamental role in our social work program by supervising all of our transgender site social workers, which has been a fantastic addition to the program. So I think, Ron, if there are any questions, you should also feel equipped and available to answer them, please. So my name is Naomi Hill. I'm the program head of the VITS-RHI Key Populations Program, and I am a social worker by training. So I was really delighted to be able to integrate social work services into what has been a very public health, nurse-driven oriented program. And the outset of this presentation is just to re-emphasize that country investments by various donors in healthcare for transgender and gender diverse communities have historically been very, very HIV prevention and treatment focused. I mean, for obvious reasons in terms of pandemic control. Yet we as a community of professionals and all of the trans-led organizations know that gender-affirming therapy is in fact the most sought-after service amongst many trans and gender diverse service users at primary healthcare clinics. And as Bruno said, if these entities are not sensitized towards the needs of these communities, then we are really failing our service users. On the right-hand side here, you will see the front page of our clinic card, which gives potential service users a brief overview of what our clinics provide. So in terms of designing a social work service, we had to consider the questions: who are our service users? What are their needs? And what is the context? In other words, where do we work? This data here is selected sociodemographic data from our baseline data and some of our service use data. And this appeared in a paper on which Rue was the lead author in the most recent GIAS supplement around HIV services to the key population community. And you'll just see here some very basic data pertaining to education, living situation, employment, and monthly income. And I wanted to point out that for most of our clients, this is a total of 3,535 clients that we surveyed, 44% had achieved grade 11 or 12, 28% were unemployed, and nearly 70% had a monthly income of less than 1,000 Rand a month. And I'm highlighting this just to give you a taste of the subset of the trans and gender diverse community that we work with in our particular clinics, and why this informed much of our service delivery design. And secondly, again, selected data of various sexual risk and behavioral factors. We see here that nearly 11% of our clientele had experienced either sexual, psychological, or physical violence. Of the perpetrators, 22% were a romantic partner, 18% family, 3% a fellow transgender community member. Nearly 30% of our clientele had reported being sad, depressed, anxious, or worried much of the time in the last 12 months. And up to 70% reported alcohol use of more than 4 drinks in a day. So clearly from what I've just shown you, there are a lot of social and structural factors alongside stigma, discrimination, and human rights violations that are impacting the particular clientele that we work with. And these obviously create barriers to access and continuity in healthcare. And in the PEPFAR space, achievement and maintenance of HIV viral load suppression. This is a snapshot of our clinic in Buffalo City. If you look up on the right-hand side, you'll see a containerized clinic that is dedicated to the trans community. And this rather enlarged sign here in the front is just a mock-up of some of our communication campaigns, which provides guidance and signage to clients when they arrive at the clinic. This again gives you an idea of our context. Bruno is working in Barra. We know that we have colleagues here from Grooterschuur. Most of our work takes place in the community. Up to 80% of our, for example, antiretroviral and PrEP initiations are community-based. So a lot of our work happens in a vehicle. You can see here one of our vehicles. We need quite sturdy vehicles to navigate the kind of terrain. And then you'll see on the left-hand side an outreach community of peer educators who have elected to be called trans agents, moving between shacks to mobilize clients. So we kind of had to say, well, in this, traditional 15-minute, I nearly said 50-hour, but 15-minute counseling session clearly isn't going to work. And what could we provide which is useful to our clients? So, first point is obviously that many of these interventions that focus on the social and structural issues fall very squarely within the social work scope of practice. And so the objectives of our program is to render donor-funded models of care more responsive to the comprehensive needs of trans and gender diverse people. In other words, broader than just seeing an individual as a public health problem walking through the door or as a patient, but as really embracing the whole person in their entirety of needs. And we very deliberately wanted to expand a nurse-driven public health model into a multidisciplinary team, which is better equipped to address the intersectional vulnerabilities which impact our population. Obviously, nurses are critical and essential. I'm not being down on nurses. It's just that we know that within the current training system, many strictly medical professionals are not given the opportunity to develop competencies across a range of areas. And for this reason, we're not only developing sensitization and competency of all of our staff, but we are bringing in the different service delivery cadres. And of course, apart from improving the service delivery to clients, we really see that we have an opportunity to field test some of the gender-affirming public health models that then could be scaled up in state, because as the state moves towards centers of excellence that Rue mentioned, they are going to be calling on evidence. And so we're using this 5 to 7 year opportunity to work with the trans-led organizations and civil society organizations to use whatever data we can generate to leverage for change in a broader system. You will remember that Rue showed you the service delivery model with the concentric circle in the middle. And I just wanted to use this to show that the 3 social work modes of practice, casework, group work, and community work, really echo the service implementation model. So at the clinic, we provide our casework, which is psychosocial support and mental health services. Within the community, we work very closely as social workers with the trans agents to mobilize the community and also specifically to support the peer educators themselves. Our trans agents are drawn directly from the community, so many of the challenges, in fact, most of the challenges that our service users experience are also experienced by our staff. So our social workers are tasked with providing psychosocial support in-house. And then on the left-hand side there, you will see that within the community, the social workers are responsible for stakeholder engagement, sensitizing both state-stroke public health players as well as the private NGOs and welfare organizations. And they're also responsible for profiling our services. So the methods that we use, fall largely into 3 areas. The first, which I've made apparent, is supporting the uptake and retention in HIV testing, prevention, and treatment. I should also say that these points are not in order of priority, but just to describe the 3 areas, that is the first. The second one is individual, small group, and community interventions that look at, generic psychosocial and structural stresses. And in line with the kind of context that you've seen we work with, most of our counseling interventions are of a brief solutions-focused modality. We had an interesting discussion, Ron and myself and the supervisor who works with the sex worker clinics, in that many of our social workers were lamenting they feel they're adding no value whatsoever because they aren't working within a traditional model of counseling. And we pointed out that
Naomi,
yes.
Sorry, Naomi, please just speak up. I see in the group chats that there are a couple of people who are struggling to hear you.
Oh gosh, I'm sorry. I'm going to try to, is that better, Rue?
Yes, that's
Rue,
better.
That better?
Yes,
Okay,
you might just have to shout on top of your voice.
Yeah, I hope I'm not, people don't feel they're being shouted at, but just to try to make myself more audible. And I'm also going to just check that my sound is on full volume, which it is. Okay, so going back to the presentation. I was just anecdotally sharing how the social workers were lamenting that they felt they didn't add value. And when we provided a theoretical framework of crisis intervention and brief solutions-focused counseling, suddenly they felt a lot more empowered in their practice because they realized that the work which they perceive to be done on the hop is actually adding a lot of value to our service users' lives. And then the third and very important and critical area is services in support of the informed consent process to initiate hormone therapy and also the facilitation of gender marker change applications. And all of this obviously happens within an overall gender-affirming framework in which we endeavor to make sure that clients and service users feel safe, feel contained, and feel it is a place and a counseling space which is very sensitized to their needs. And this is where Ron has been very instrumental because none of our social workers had any experience in working in a gender-affirming space until they joined the program. And so we have an ongoing supervision process to ensure that our services are of the highest possible quality. I'm not going to discuss the following two slides in detail. I know that they will be circulated. It just provides a little bit more granular detail about our role, specifically in relation to the HIV cascade. When I say cascade to people who are maybe not directly in the health space, it's described here in the orange blocks on the left, where we proceed from prevention activities to HIV testing, the initiation of pre-exposure prophylaxis for people who test negative, or ART initiation, antiretroviral initiation for those who test positive. And you'll see in the green blocks a number of specific activities in relation to those. So just to speak a little bit about our results, I'm speaking about the last financial year in 2022. You will see here that we saw in total across the 4 sites nearly 300 clients, with Cape Town having the highest number of clients and Nelson Mandela Bay being the lowest. In terms of the presenting issues, most clients presented either for, on the left-hand side of the chart, viral load suppression, or on the right-hand side for mental health. Quite a lot, 19, around gender-based violence. And then of the large block 277, which is the other, you'll see variously it was around antiretroviral initiation and treatment, PrEP, generic health problems, parenting skills, bereavement, child neglect. And I see a couple of the points seem to have been hidden in this slide, but there was also reference to family conflict and relationship difficulties, and of course, interpersonal violence. Moving on to some of the outcomes around the HIV cascade. Rue has already mentioned that we have shown that viral load suppression amongst transgender clients has increased from 76 to 89% with the support of hormone therapy, but also this is the period, this data specifically since social work services started. So we cannot attribute all of the uptake or the increase in viral load suppression to the social work services, but we do anecdotally think that it has made a real difference. And we've certainly seen with individual service users who have been virally unsuppressed but didn't have any medical issues like drug resistance, that with the intervention of a social worker, there has been much better continuity of treatment. And then the last point here is about the task shifting with psychologists around informed consent. And I wanted to show a little bit here around this. This is just one example. We developed with the trans and gender diverse community in Johannesburg specifically, a communications campaign to invite our service users into the clinics. You'll see here it's based around the location pin, which is something that everybody identified with. And it has a series of slogans which are in the languages mostly used by the clinics in the different areas. This one in English is "We are here," and it varies to say "We are here for you," "You can talk here." And this specific item here is a guide for trans women and for trans men coming to the Wits RHI clinics on the informed consent process. This is just the front and the back of the pamphlet. The back pamphlet demonstrates the informed consent form, which service users sign, but the pages in between, with the support of Elma and Chris, provide a lot of very readily accessible information around the informed consent process, what clients can expect, both at a medical level, at a social and at a psychological and emotional level. And this is an example of a tool that the social workers will use in collaboration with the psychologists to discuss with service users any issues which they might like to address in this process. And I use this as an example of where we are doing some task shifting between a role that's very traditionally been played by psychologists in order to make sure that we could scale this model up and have data to demonstrate its benefits within the public healthcare system. And then finally, this is a success story which has been achieved by our social workers in Nelson Mandela Bay. And it just profiles, with her permission, the story of one of our service users, Lulu, who successfully changed her gender marker and her identity document at the Department of Home Affairs. And we have achieved this in the other sites as well, and we hope to scale this number up. And this is something which the social workers have been very involved with. Some of the key priorities going forward is increased referrals to legal literacy programs, greater attention to the children of some of our service users, particularly in relation to safe spaces and housing. We are increasingly linking clients to organizations that provide food parcels and support for unemployment. There's a continued focus on gender-based violence, and then also documenting and writing up the story and the evidence of the effect of the psychosocial support interventions in our program. And in conclusion, we can see that social work interventions do help to enhance the responsiveness of what are essentially primary healthcare services to the express needs of trans and gender diverse people. And we hope that by showing the value of complementary social work services in HIV service delivery platforms, we can increase country investment by donors, but we can also really advocate within the Department of Health and Social Development for services such as these. So this presentation has been relatively descriptive to give people an understanding of the work that we do. And I really do want to, at this point, acknowledge our 4 social workers who Ron knows very well, Buntu, Renilwe, Tandeka, and Toko. I'm delighted to say that Toko has now gravitated from being a social worker to being the site manager in Port Elizabeth. They were supported in the presentation of the data by our M&E team, Vusi and Jolie. But these social workers, as Ron says, are really breaking ground in terms of working in a multidisciplinary team within dedicated gender-affirming healthcare services at a primary healthcare level. And we're very, very proud of the work that they do. Thank you very much.
Thank you very much, Naomi.